Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Fall 2013 Alabama Department of Public Health Nurse Practitioner Update. Our objectives today are to explain the techniques for obtaining a medical and family history according to ADPH clinical protocol, describe essential components of a well-woman exam according to ACOG guidelines, discuss the essential information necessary for documentation in SOAP format, discuss implementation of a problem list in the patient's ADPH clinical health record, identify the risk factors and implications associated with diagnosis of PCOS and metabolic syndrome, explain the clinical significance of PCOS and metabolic syndrome, describe the management of PCOS and metabolic syndrome as it relates to ADPH clinic protocol guidelines, and describe the process of submitting the department's ARIA report and explain the rights of minors related to protected health information. If you have a question about anything being discussed today, please call or email our faculty presenters during our live broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online, and you will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses for today's program. The ADPH is an approved provider of continuing nursing education by the Alabama State Nurses Association. The association is an accredited approver of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. Instructions on how to do this can be found at the bottom of the sign-in sheet. While content may continue to be relevant, CE credit will only be awarded for 2 years from today's date, which is November 15th, 2013. There is no financial relationship between the planners of this program and the speakers. There is also no commercial support for this program. The Alabama Department of Public Health does not endorse any product that may be displayed in conjunction with any activity that might be demonstrated, nor will the department discuss any off-label use of products. The Alabama Department of Public Health is now charging viewers who are not employees, contract employees, or retirees of the Alabama Department of Public Health for CE certificates. Registration and participation in both our live and on-demand programs will continue to be available at no cost. More detailed information and specific instructions can be found on our website. Please note the content of this program is based on the policies and procedures of the Alabama Department of Public Health, Alabama and federal statutes, rules, regulations, and guidelines. Viewers not employed by ADPH should always check to clarify whether the content is accurate according to the statutes, regulations, and policies of your respective jurisdictions or agency. So let's meet today's faculty presenters, all from the Alabama Department of Public Health, and all these ladies I'm sure are well known to you. Here to my right we have Samaria Dunson, the Assistant General Counsel. We have Deborah Davis, Gabi Darch, and Beth Allen, all nurse practitioner seniors. So welcome, ladies. I'm looking forward to the program today. You all are so knowledgeable, and I really appreciate your time and effort it's taken to pull all this material together. So let's get started. Samaria.
Well, I'm really excited to be here to talk with you all about a number of things. One of those things would be our ARIA reporting. Now, ARIA stands for Automated Report of Incidents and Accidents, and we actually began ARIA reporting on 9/9/9, so that's September the 9th of 2009. We get a significant number of ARIA reports in each year, and we actually capture that information so that we can look at trends that may be happening within our county health departments, within the tower, out at our lab, or anywhere where our employees are having any types of incidents or accidents. I want to talk to you about how to log into the ARIA system and do a report. The first thing you want to do is go to the ADPH website. So that's adph.org. In the upper right-hand corner, you'll see where it says log in. You'll click there. From there, you'll notice about midway down the page, there's a section that says ARIA, Automated Report of Incidents and Accidents. You'll click on that. And from there, it'll take you to LCMS login page. Many of you all, ever since doing the HIPAA video, will remember your LCMS username or password, and you'll enter that. After you enter that, it'll take you to our general ARIA page. You'll notice at the very top of that page, there's a place for life care and home health, and those employees will click the very top of the page before beginning their ARIA report. For everyone else, you'll complete the ARIA report as it is. It's really very self-explanatory. As you get towards the bottom of that page, it'll have several items that you can choose from for the reason for your report. As you can see, the first thing would be automobile accidents. So those are going to be anything that happens in an automobile while you're doing work hours, or if you're in a state motor pool vehicle. Breaches, losses of depths of protective health information. Obviously, that's going to be to help us trend any of our HIPAA breaches or issues related to that. Confrontations, verbal, physical, or with weapons, and you'd actually be surprised. We actually have a couple of those each year. Generally, in our county health departments, I'm very happy that they're not in my particular bureau. We also have illegal drug possession or use. Very happy to say that we've not had any reports on that in recent years. One of the biggest things that we get reports on are falls, and they're not generally by our employees. They're generally reporting falls by patients in our home health program, and people do a very good job of reporting those types of incidents. Other incidents that may be reported are losses, a theft of property or property damage. So this is going to be if your purse gets stolen out of your office, or if your laptop or cell phone gets stolen. Those are some of the things that would be reported for that. We have medication errors that may be occurring for whatever reason. Either the medication is expired, or they gave the medication to someone that may not be the appropriate age. Any of those types of things would need to be reported there. Any type of physical injury or occurrence. Also, we began doing professional practice issues at the beginning of 2013. So if there's an issue with any of our professionals, social workers, nurses, doctors, we're reporting those, and suspected abuse of patient or neglect or exploitation. So if you're making reports to DHR with regard to any of our patients or any of our clients, you would also capture that in an ARIA report as well. After you click on one of those primary reasons for report, one of the interesting things about the ARIA system is it'll take you to the page that's appropriate for you. So if you've done an automobile accident, the very next page will be things that are associated with the automobile accident. The same thing for medication errors. So all of those things are kind of done behind the scenes, and you'll just continue to fill out the information as you go. And then finally, at the end, you will press submit. One interesting thing is that you'll see on this slide that it says Alabama Department of Finance, and those are for automobile accidents specifically. With automobile accidents, you're required to report certain things to that particular department. So we've tried to make it easy for you, so you don't have to go and try to find their website. You can do it there. And for everyone else, you'll just press submit. Now, once an ARIA is submitted, it's actually going to be emailed directly to my email address and also a paralegal within our office. At that time, we'll look at it. We'll decide who needs to receive copies of that report, and if we need to provide you any type of follow-up advice, or if we have any questions, then we'll ask you about that at that time. Another thing that's very important that I want to talk with you all about has to do with when individuals can consent to treatment. This Alabama Code Section 2283 discusses when physicians with their own judgment can decide to provide treatment for individuals and minors when the individual can't themselves consent. So this would be a result in any type. They would do that as long as there's not, if there's any type of issues associated with the person where it's immediate. And if they think that it would be dangerous to wait for consent, then they can go ahead and provide treatment, and the law allows that. The next code section deals with when minors can consent to treatment. This is something that comes up pretty often. It's important. We always know that the magic number is 14 for when individuals can consent to treatment. But also, if an individual has graduated high school already, which is probably a pretty smart person if they've graduated already, but if they've graduated, they can consent to medical treatment. Also, if they're married, or if they're now divorced, if they've been married, they're an individual that can consent to treatment. And also if the individual is pregnant, if they're a minor and they're already pregnant, they can consent to medical treatment for themselves. And one thing that comes up often is when an individual can consent for medical treatment if they are coming for treatment for sexually transmitted diseases. And the magic number for that is going to be 12 years old. And what the law actually says about that is that the department, the State Board of Health, decides which diseases are designated sexually transmitted diseases, and they can, minors 12 years or older can consent to treatment for any type of STDs. Their consent is valid and binding. One of the reasons that it's important to note that is that for many contracts or anything like that with a minor, because of their status of being a minor, once they reach the age of majority, many times they can go back and contest that. But what this statute does is say, oh no, if you're a minor and you're consenting to this type of treatment for this purpose, then once you reach the age of majority, you can't turn around and say, oh, I shouldn't have done that. I changed my mind. I want to sue for any type of liability issues. Also, the one thing that is important to note is that medical providers may inform the parent or the guardian. I know that in public health, that's one of the things that, just for the trust of our patients, we tend not to do that, but that is something that is considered in the law for that. And their consent, the minor's consent, is not voidable. They can't just affirm it later when they reach the age of majority. And so those are the issues as it relates to, that's just some more of the provision of that statute of when minors can consent to sexually transmitted disease treatment. Now, I wanted to take this opportunity, since I had your attention, to address some frequently asked questions that we get in our office. One of those things are when you request medical records of another provider and they provide you more information than you actually needed. Maybe what you wanted was x-ray or lab results and they provided you the entire medical record. Well, that can be a lot for you to try to keep up with all of those records and that type of thing. And one of the things I wanted to express to you is take the information that you need out of it and make sure that you shred or destroy the other information. You don't want to throw it away in a trash can, but you want to make sure that you appropriately destroy it because that provider would have violated the minimum necessary rule. But just because they did that doesn't mean that you have to now keep up with more information than you need. Another thing that comes up pretty often, and we get kind of calls when people are in a panic, and that is the law enforcement exception. I think whenever somebody from the sheriff's office or any type of police officer shows up, I know it would make me pretty nervous. And people always want to know, what do we have to provide them? What do we have to give them? And the law is actually very specific about the information that you would give to a law enforcement officer. You can provide them with the individual's name and address if they're requesting that. You can also provide them with their date of birth or their place of birth, as well as their social security number, what type of injury they have, like if they have a gunshot wound or a knife wound. You can also provide them information that are distinguishing characteristics of that individual. So let's say if the individual has a mustache or a goatee, or they're particularly tall or short, any of those types of things that would allow that law enforcement officer to identify the individual that they're looking for. One thing I want to be very that I definitely want you all to note is that we don't allow law enforcement officers to go into our clinic and any of our treatment rooms or anything like that. If a law enforcement officer wants to speak with one of our patients and that patient is in the middle of an appointment, then we ask the law enforcement officer, wait till that individual gets ready to leave the county health department and you can approach them in the parking lot. We don't want our patients approached by law enforcement officers in the examination room or while they're in the county health department. And all of the law enforcement officers that we've dealt with so far have been very cooperative with that. Another thing that I wanted to speak with you all about are subpoenas and authorizations for the release of protected health information. Many of you already know that if you receive a subpoena or an authorization, that you're to fax that to our legal office so that we can look at it and make sure that it has all of the relevant HIPAA language that would allow us to release the information. One thing that I also want to be clear about is our office has looked at and approved the CHR-6, which is the department's release of information. And as long as that information is complete and the person has signed it and they've completed all the aspects of that document, you can rely on that CHR-6 release to provide the information that the person is requesting. What we're really looking for when we say that we want to see authorizations is if there's an attorney's office authorization or an authorization from another provider, then we want to look at those to make sure that it has everything that it's required to have. As we talked about when we did the HIPAA training, we want to make sure that people are really understanding the faxing procedure for protected health information, which is to make sure that you are contacting the individual that you're sending the fax information to make sure that they're ready and available to receive the information, and that you make sure that you receive a confirmation of that, that the fax has gone through, and please make sure that you're faxing it to the right number as well. We really just talked about accessing minors' records. One thing that when I was talking to a number of people in our different areas that has been, what I think is a very good thing, is that when, let's say a person, a minor has come in for medical treatment, maybe their mother or father came and signed for them at one time, and now the minor is coming in on their own to sign for specific treatment. What a number of our county health departments, and this is something that I like to see, are doing is, rather than saying, okay, on this date, that information belonged to the mom, on this date, that information belonged to the minor. It creates a lot of problems later if someone comes back and the mom wants a copy of Samaria Dunson's health record, then you have to figure out, well, which did Samaria sign for and which did the parent sign for? What a lot of you all are doing, and this is something that I'd like to see that we keep doing, is once the minor comes in and presents themselves for treatment and signs for the record, they're saying the minor really owns that record at that point. So they're wanting an authorization from that minor before they provide information further. And one other thing that's come up that I wanted to make sure that there was no confusion about had to do with disclosures from county health department to county health department. We're always going to be able to communicate with each other. We're all one entity in the Department of Public Health. So please understand that you can still scan things in and email them through Lotus Notes to other county health departments, fax information to each other, communicate with each other very freely. We're all considered to be one covered entity. And one more thing that I wanted to note, because this just came up with our STD division, it had been the case so far that we were all faxing all types of PHI. But just so to give you all a heads up, one thing that I know that they're looking forward to in the future is to say, we don't want to fax information that has to do with STDs or communicable diseases, which I'm very satisfied about. You'd be really surprised, or maybe you wouldn't be surprised at all, but people don't have a problem when you're breaching, their high blood pressure record or cholesterol or anything like that. People do have a problem if you let people know their weight a lot of times, but people really get very upset if there's a breach of STD or communicable disease information. So I'm very happy that we're looking forward to implementing that procedure to make sure that we're not faxing those types of records.
Okay. Well, thank you. So, Deborah, are you ready?
I guess.
All right. Thank you, Samaria. That was very, it's always very helpful, and I love the frequently asked questions. So that's really going to help you. Of course, you all will have a chance at the end of the broadcast to be able to ask Samaria any questions, so please take note of those. And we'll moving right along now to our nurse practitioners. Deborah.
Okay, we're going to be talking about a really big problem that we see almost every day in the health departments, and that is PCOS. I call it a really bear of a problem. I want you to be able, at the conclusion of this presentation, to understand and define PCOS and metabolic syndrome. We want you to be able to identify the risk and implications associated with the diagnosis of PCOS and metabolic syndrome, and be able to explain and review the clinical significance of PCOS with our patients and the possibility of metabolic syndrome, and describe the management of PCOS and metabolic syndrome and relate those to our public health department guidelines. PCOS is a real bear of a problem, and so that's this is a beautiful little bear, so we're going to talk about it. Polycystic ovarian syndrome is a clinical syndrome characterized by obesity, irregular periods or amenorrhea, and signs of androgen excess like hirsutism and acne. In most patients, the ovaries also will contain multiple cysts. In women who have PCOS, their hormones will fluctuate. One of those fluctuating hormones is the sex hormone binding globulin. The sex hormone binding globulin is decreased, resulting in more free testosterone in the system. And this accelerates the sebaceous glands, resulting in one of the symptoms of PCOS, and that's acne. Another one of the symptoms is caused from the free androgens, or the testosterone, that's converted to an additional hormone in the peripheral tissue, and it results in the increased hair growth that we see in our patients in the terminal hair follicles, and that's what we call hirsutism. Also, the decrease in the sex hormone binding globulin is inversely related to high levels of insulin in the system, which in turn leads to insulin resistance and results in the thickened, dark, velvety texture of the skin that we see, and that's called acanthosis nigricans. In 2010, the Third Consensus Workshop Group met in Amsterdam to review women's health, and they looked at PCOS and they made a definition. The broad guidelines that they came up with included oligo ovulation or anovulation, hyperandrogenism, the clinical or the biochemical hyperandrogenism, and polycystic ovaries that are noted on ultrasound. PCOS is the most common cause of infertility in the United States. 1 in 5 infertile couples experience PCOS. We have to remember that PCOS is the consequence of chronic anovulation. It is not the cause. So I want to talk about basics. If you recall, in the normal menstrual cycle, the estrogen surge during the follicular phase of the menstrual cycle causes the dominant follicle release, leading to ovulation. With PCOS, they have an abnormally high androgen concentration, which impedes the follicular maturation, promoting breakdown of the follicle and predisposing to a chronic anovulatory state. The androgens released by the follicle are changed to metabolites that further negatively affect the estrogen production, preventing formation of a viable follicle. The LH may be at a normal level or slightly below normal, so we do not have the LH surge. The follicle doesn't mature and ovulation doesn't occur, resulting in a cyst on the ovary. If you'll note in the slide, in the proliferative phase or follicular phase, it's day 1 through 14 of the cycle, estrogen is needed. In the secretory or luteal phase, day 14 through 28, progesterone is needed. As a general rule, anovulatory women seldom have regular periods. However, some people will note that they have regular periods for a while and then they start having amenorrhea or very rare periods. PCOS is a bear of a problem. We see anovulation, we see ovulatory dysfunction that causes the oligomenorrhea or amenorrhea. They may have the androgen excess, which increases the risk of metabolic syndrome and causing hirsutism. Other common features of PCOS not included in the diagnostic criteria is abnormal hormone secretion. Women can have the abnormal hormone secretion, which leads to insulin resistance and dyslipidemia. Insulin resistance is the condition that is central to the etiology of the syndrome. Over time, the androgen excess increases the risk of cardiovascular disorders like hypertension. Most women with PCOS will experience these menstrual changes. They have anovulation, which is chronic. They have this chronic follicular phase, which occurs secondary to the constant estrogen stimulation, and endometrial proliferation or buildup and increased vascularization of the endometrium results. They have a thickened endometrium, which may become unstable and fragile and eventually rupture, causing irregular and prolonged bleeding in the anovulatory woman. A woman who with PCOS is always in a follicular phase. There's no progesterone there to stabilize the endometrium. And if you'll notice in the slide, once the endometrium begins to break down when in a normal menstrual cycle, usually with PCOS, it doesn't completely break down. It doesn't go all the way down to the basal layer. So some of these women may have crumbling of the inner lining, which causes that irregular and prolonged bleeding that they may experience. Endometrial cancer can arise from the inner layer of the endometrium when it's really thick. The endometrium gets thick in response to the estrogen stimulation. They have a chronic lack of progesterone, which causes unregulated growth of the endometrium, or what we call endometrial hyperplasia, and this is a precursor for endometrial cancer. The excess estrogen without progesterone causes the endometrial hyperplasia. If ovulation does not occur, progesterone is not made and the lining is not shed. Over time, the resulting thickened endometrial changes can become abnormal and lead to cancer of the uterus. There are several different types of endometrial hyperplasia, and I'm not going to go through all of those. I do want to talk about the last one just a moment, and that's the endometrial hyperplasia with atypia. The endometrial cells with complex hyperplasia with atypia will generally have a bizarre appearance, and this is what, over a period of time, can progress to endometrial cancer. And what I really want to say about that is if there's any suspicion or risk of endometrial cancer, those patients need to be seen by a gynecologist, and they need to see also a GYN oncologist to obtain the appropriate staging of the cancer so that they can receive the right kind of treatment. With endometrial cancer, we have to remember that it's the most common gynecologic malignancy in the United States. An estimated 41,000 women will be diagnosed this year with the disease. The overall survival rate is excellent if the disease is confined to the uterus. The factors that increase these risks can be obesity, chronic anovulation, early menarche or late menopause, hypertension, exogenous estrogen use without progestin. The symptoms of endometrial cancer can be irregular, unusual, or heavy vaginal bleeding. I want to note here and stress any amount of bleeding or spotting after menopause, even just a tiny bit, can be a symptom of endometrial cancer. And if these women experience pain with intercourse, pain with urination, or lower abdominal or pelvic pain in conjunction with the irregular or unusual bleeding, they definitely need a referral. So let's look at the PCOS signs and symptoms. These women will have a premature adrenarche, and what that means is they have the excess pubic hair or excess axillary hair, and they can have it at a young age. Also, these women may have experienced an unusual early body odor. They will have it in girls that can be as young as 6 or 8 years of age. They may have excess hormones, and they may have the unusual cystic type acne. Other typical symptoms can be obesity. They have the hirsutism, which is the body hair growth on the upper lip, the chin, around the nipples, and the linea alba of the lower abdomen. They may have irregular periods. They may also experience the balding or on the crown of the head or the male pattern baldness. They may have the acanthosis nigricans of the axilla or the neck or the skin folds, the knuckles or the elbows. Remember that that's the dark, thick, velvety texture to the skin, and that is an indication of high insulin levels in the peripheral tissue and is secondary to probably insulin resistance. Just to review the Rotterdam group diagnosis, they said that their diagnosis is if a woman has oligo ovulation or anovulation causing menstrual irregularity, clinical or chemical evidence of hyperandrogenism, or the presence of polycystic ovaries, the likelihood of PCOS does exist. There were some other national organizations that met with this group, and they wanted to include some additional information in the diagnosis, and this was to exclude other types of conditions that may present with the same type symptoms but are not PCOS, and that would be congenital adrenal hyperplasia, androgen-secreting tumors, or possibly Cushing's syndrome. With PCOS, some doctors may want to examine or check for the biochemical changes. That could be the serum testosterone. Some doctors look at the free testosterone. It's a better level to check, or the total testosterone. They may also check the FSH levels. For our concerns and the best information that we have, the best lab information is usually a prolactin level. We're looking for hyperprolactinemia, or we're also checking the TSH, or thyroid stimulating hormone. Some doctors may want additional lab values to check for those other conditions, and that would be to look at the Cushing's syndrome, the congenital adrenal hyperplasia, the tumors that we just mentioned. But one of the things that we are most interested in, especially in family planning, is this metabolic syndrome. We want to be able to rule that out. We look at their blood pressure. We look, these patients also need their serum glucose checked, and they need a lipid profile. So let's look at the definition of metabolic syndrome. Metabolic syndrome is characterized by a group of risk factors for cardiovascular disease, for dyslipidemia, and type 2 diabetes. One of the most significant issues for our patients with PCOS is this risk of metabolic syndrome. Metabolic syndrome is the predictor for cardiovascular risk and is associated with diabetes. These women are more at risk if there is a family history of type 2 diabetes. The prevalence of insulin resistance with PCOS is very great, and it's more so in women who are obese or have the central belly fat or have a BMI of 30 or more. And this is seen in the ACOG practice bulletin about PCOS. Metabolic syndrome is a constellation of metabolic factors which includes the belly fat or abdominal obesity, the dyslipidemia, which is the low HDL-C, the elevated triglycerides, and excess of the small dense LDL particles. They may also have hypertension. They may have insulin resistance or impaired glucose tolerance. They may have a systemic pro-inflammatory metabolic state, which makes them more at risk for clotting problems. These women clinically will have the excess intra-abdominal fat, mostly with a waist size greater than 35 in women. They may have the they may have the elevated serum triglyceride levels. They may have the decreased HDL cholesterol. They may have hypertension, and ACOG notes the hypertension level to be 130/85 millimeters of mercury. They may have elevated fasting blood glucose greater than or equal to 100 milligrams per dL. So to summarize metabolic syndrome, we have to remember that insulin resistance has been reported in approximately 50 to 75% of women who experience PCOS, regardless of what their BMI is. The risk for insulin resistance is higher in women who have this chronic anovulation, if they have polycystic ovaries, if they have hirsutism, and a family history of these problems. We need to keep in mind that insulin resistance is the result of metabolic and hormonal influences that contribute to an increase of insulin production and a blocking of the insulin usage in the peripheral muscles and tissue, resulting in a higher glycemic state. So, PCOS is a real big booger bear. The clinical significance is the vicious cycle that these women experience. They have insulin resistance where the body is resistant to the effects of insulin, resulting in a hyperglycemic state. The pancreas overcompensates by producing more insulin, causing the ovaries to produce more androgens. And then they have more symptoms like hirsutism, acne, oligo-ovulation, or anovulation. They have a hyperglycemic state secondary to the increased insulin production, and over time can lead to type 2 diabetes. Now, I want to review just a second the difference between type 1 and type 2 diabetes. Type 1 is characterized by failure of the pancreas to secrete insulin. Type 2 diabetes is characterized by the resistance of the muscle, the adipose tissue, or the liver to the glucose-lowering effects of the insulin, and failure of the beta pancreatic cells to secrete sufficient insulin to compensate for the insulin resistance. Insulin resistance is often related to obesity, especially if it's the central abdominal fat that we see. The cardiovascular risk in these women is very great. The low serum sex hormone binding globulin in most women with PCOS is linked to decreased levels of the HDL, or the serum high-density lipoprotein cholesterol. I want you to understand that this is the most cardioprotective lipid in the body. And so when the HDL levels are low, patients are more at risk for cardiovascular disease. So they have the decreased HDL, and they have the increased free testosterone levels, which can be associated with the systolic and diastolic blood pressure levels, and that also leads to hypertension. Coronary artery disease is the leading cause of death in women in the United States. The Framingham Heart Study has shown that the effects of diabetes on cardiovascular mortality is greater in women than in men. And the biggest change that can affect these women is lifestyle changes, and especially for the HDL cholesterol. When it's low, we have higher cardiovascular risk, so we can do something to change that. And one of the biggest factors that can change that is exercise. An additional factor that we see in women who have the metabolic syndrome is the elevated C-reactive protein. C-reactive protein is directly linked to a systemic, it is a systemic inflammatory marker for these women. So they have increased coronary inflammation, they have increased clotting problems, and so they are more at risk for cardiovascular disease and all of the situations that can occur with that, like thrombosis. The significance of dyslipidemia is that there is atherosclerotic cardiovascular disease is the leading cause of death in men and women, and it's the underlying reason for angina, unstable angina, acute myocardial infarction, sudden cardiac death, and ischemic stroke. The risk factors include elevated levels of the atherogenic lipoproteins, which is the LDL, the elevated triglycerides, and the low levels of HDL. Cardiovascular disease accounts for approximately $448 billion worth of direct and indirect healthcare costs annually. And again, I repeat that more women die from cardiovascular disease than men, and that was shown in the Framingham Heart Study. More women die from cardiovascular disease than from cancer, from stroke, chronic lung disease, Alzheimer's, unintentional injuries, diabetes, and pneumonia combined. I want us to look at the total cholesterol values that we see. There was a large meta-analysis study that was done a couple of years ago that looked at the total cholesterol values in women, and it showed that women who are less than 65 years of age, if they have a total cholesterol value greater than 240, they had a 2.5 times greater risk for cardiovascular disease than women who had normal values. With increasing levels of LDL-C, those are associated with increased risk of cardiovascular disease. There's also a beta phenotype that's also accompanies the insulin resistance and is implicated in cardiovascular disease. Another way to really say this is that the cardiovascular disease is a primary clinical outcome of metabolic syndrome, and diabetes is the major risk factor for development of the cardiovascular disease. There was a new study recently that just came out, actually it came out this week, that showed that most people with obesity, 1 out of 3 is what they're saying, may need the cholesterol lowering medication. And it's because of their increased risk due to the increased excess abdominal fat that they have and the increased risk that they have. So we have to think about who these people are, and really they're the patients that we see almost every single day. They have the excess abdominal fat that puts them at risk for a fatty liver or cirrhosis. So when we're checking our patients with liver function studies for some reason or another, it may be that they have an elevated liver function study that's indicative of this fatty liver more so than alcohol-related or hepatitis or whatever. It may be actually due to the fatty liver. These patients also experience this increased inflammatory and thrombosis risk, and so they are more at risk for blood clots. These women also experience the prolonged chronic and ovulatory cycles that lead to endometrial hyperplasia and the increased risk for uterine cancer. They have increased problems with chronic renal disease. They also could develop, as we've just mentioned, the coronary artery disease. And I wanted to stop for just a second and talk about referral of patients who have these risk factors or symptoms. If they have the anovulatory cycles, and we write out a referral, we don't need to just say, please evaluate their amenorrhea or their prolonged periods. We need to state specifically what we're referring them for, what we want evaluated. And that it usually is, we want you to evaluate or rule out for possible insulin resistance or metabolic syndrome. So we need to say it a little more specific so the doctors that we refer to will really know what we want. The treatment guidelines by ACOG is healthy diet and exercise. And I can't stress this enough. It's weight loss, weight loss, weight loss. Even a 5% reduction of weight loss can result in a return to the ovulatory state for some of these women. Some doctors are also, if a woman is desiring a pregnancy, they may opt to use metformin in conjunction even with Clomid to improve ovulation. Metformin decreases the body's resistance to the increased blood sugar, and it decreases the circulating androgens. The doctors may also want to manage their cardiovascular risk factors. If a patient is not seeking pregnancy, it would be great if they were on a combination low-dose hormonal contraceptive. This is recommended by ACOG as management of their menstrual disorders, and especially good if there are no other contraindicated factors, like health concerns, like their BMI greater than 34, their smoking, or their migraines or blood pressure issues. ACOG says that if a combined pill is not used, then a progestin only should be used. Their recommendation is the progestin only pill or the progestin containing IUD device. And this is protective for these women against uterine hyperplasia. We need to make it clear to our patients that after they have completed their evaluation to rule out endometrial hyperplasia, that they need to, if they're not seeking a pregnancy, they need to be on a hormonal contraception to help protect them against the endometrial hyperplasia and possibly uterine cancer. It is protective for them. I do want to mention that there were no studies that addressed the long-term use of Depo-Provera or the oral Provera use. Other treatment options, if you'll notice on page 66 of your clinic protocol manual, there are risk factors to consider, and you should do a phone consult that's required actually to initiate and continue both the progestin and the estrogen-containing methods. The menstrual history is very important when you're doing your consult. You need to note how old the patient is and how long that amenorrhea has been present. Keep in mind that no one size fits all. It is important to note, too, when you're doing your consult, has the patient been on Depo-Provera in the last year? Also, you want to make sure that your patient has had a pregnancy test before you call to make your consult. Menstrual history compatible with suspected PCOS necessitates an endometrial assessment and evaluation to rule out the endometrial hyperplasia prior to initiating hormonal methods. Metabolic syndrome predisposes to the cardiovascular disease, to stroke, to type 2 diabetes. Therefore, this patient needs a medical workup and ongoing medical management. PCOS and metabolic syndrome is a bear of a problem. We see more patients who are overweight or obese. They have the irregular menstrual cycles. They have the hyperandrogenic characteristics. We need to evaluate their current health risk associated with PCOS and metabolic syndrome to prevent future health concerns for these patients. These young women who exhibit signs and symptoms of PCOS really have a bleak health future if they're not properly counseled, if they're not evaluated, and if they don't initiate some type of change in their lifestyle habits. And I know some of the nurse practitioners utilize nutritional handouts, the BMI chart, to show the patients where they are and where they need to be. Any little things that you can do like that to help stress to your patients to change their lifestyle, to change their eating habits is very important. The take-home message for my presentation today is that PCOS is significant because it is associated with infertility, it's associated with uterine cancer, with insulin resistance, metabolic syndrome, and diabetes. It's also associated with dyslipidemia and cardiovascular disease, and this is very important for our family planning patients. I want to close with a little poem, is that in this lifetime, I'm a woman. In my next lifetime, I may come back as a bear. When you're a bear, you get to hibernate. You do nothing but sleep for 6 months. I could deal with that. Before you hibernate, you're supposed to eat yourself stupid. I could deal with that. When you're a girl bear, you birth your children who are the size of walnuts while you're asleep, and you wait to partially grown, cute, cuddly cubs. I could definitely deal with that. If you're a mama bear, everybody knows you mean business. You swat anybody who bothers your cubs. If your cubs get out of line, you swat them too. I could deal with that. If you're a bear, your mate expects you to wake up growling. He expects that you're going to have hairy legs and excess body fat. Yep, I'm going to be a bear.
Okay, that was so good. Thank you. And you know, with all this talk of abdominal fats, made me real uncomfortable. So I think we need to take a break, go run some stairs, and do some sit-ups. So with that, we're going to take a 10-minute break, and we'll see you all back at 10 o'clock. Hi, and welcome back to the Alabama Public Health Training Network. We're going to continue on with our nurse practitioner training today with the history taking and with the SOAP notes. I do want to remind you that at the end of the broadcast, we will allow you to ask questions. So from time to time, you will see the email address or the phone number that you can call toll-free. I want to encourage you to take advantage of the experts while they're here. We also have in our audience Dr. Grace Thomas and Beth Nichols and Lori Stout, so while they're all in one room, take advantage of it. So without further ado, we're going to go ahead and start with Gabi Darch, and then after Gabi, we'll move on to Beth Allen. Welcome, Gabi.
Thank you. It's great to be here. We wanted to include the nurses in this update as well because we wanted to talk a little bit about the CHR12 form and doing health histories. So the question is, why do we need this? And that's a good question. We've all taken medical histories before, but the reason that we're revisiting this is that we wanted to be sure that we're all on the same page. We wanted to develop some standardization, and we know that we can't do everything the same way, but we wanted to, like I said, have a little bit of a standardization. Okay, so here. Okay, some of you are new to the ADPH system, and some of you have been utilizing our history form for some time. We want to know the why of what we're doing, and we figured that would help us perform more effectively and efficiently. And we've been all hearing about efficiency lately, and we're going to be hearing about it more and more. So this is kind of a back to basics. Okay. So to start an interview, okay, I told you we were starting at the very beginning. You want to begin in a private, comfortable place. You want to make sure that you're able to close the door. You don't want to interview in the lab area or in a common area where your conversation could be overheard. You want to introduce yourself with your full name so the patient knows who they're talking to. So I would say, hi, I'm Gabi Darch. I'm one of the nurse practitioners. I'm going to be talking to you about your health history today. And another thing that you'll be hearing more and more about is the idea of asking open-ended questions. So questions that require more than just a yes or no answer or a short answer. So one of the ways you can ask that is to say, what can I do for you today? Or what brings you here? And then fine-tune it a little bit more and saying, are you having any problems today? We want to verify age. We want to ask about allergies. And importantly, when asking about allergies, we want to find out what happens when they take a certain medication. So we've had incidents where we've written down that a woman has a penicillin allergy, when in actuality she took penicillin when she was 2 years old, and her mom said she had a rash, and she never took penicillin again. So this is important because we give a drug, Rocephin, that shouldn't be given to somebody that's allergic to penicillin. So you want to find out what exactly happens. If they have anaphylaxis, obviously we don't want to give them the penicillin. The other issue is with syphilis, especially in the pregnant woman, penicillin is really the drug of choice to treat them, so they would have to go through a desensitization period prior to getting penicillin. Okay. Another, just kind of sticking with the theme of the allergies, a lot of our patients are allergic to latex, and so we want to put that prominently on the chart that they're allergic to latex. We want to have other types of gloves in the clinic that don't contain latex, and I want to put in a plug for the nitrile gloves. Those clinics that have the blue or the purple nitrile gloves, they're wonderful. And I don't have the order number, but I'm sure we can find it. But I think I would recommend that for your clinics. Okay, asking about taking medicines or supplements. I would say, are you taking any medicines or supplements? But the better way of saying this, the open-ended way, is to say, tell me about any medications that you're taking. So it kind of puts the ball in the patient's court, where it's not just, well, I'm taking aspirin and blah, blah, blah. It makes them want to say a little bit more. That's the idea. And this is well documented in your protocol manual, but I just wanted to throw in a couple medications that can interact with birth control pills. There's an herbal that I don't know how popular it is anymore, but it was taken by women for depression, called St. John's wort. That decreases the effectiveness of birth control pills, the combined pills. Topamax does. That's used to treat migraines. And then there's another medication where kind of the flip side happens. It's Lamictal. That's given for seizure disorders, and the Lamictal is made less effective by combined birth control pills. So that's something that we need to watch for. Any anti-seizure drugs we want to look at carefully, because some of them are okay to take with birth control pills and some are not, like Dilantin and Phenobarb, and there's a list of others. Okay, so we want to be real sure, moving on in the history, that we specify, be very clear about the reason for the visit. So, I mean, this is an obvious example that she's there for her family planning annual. Another thing might be that she's complaining of a right breast mass. It's been lasts for 2 weeks. If you get any more information or elicit any more information from the patient, write that down as well, because if you're basically trying to draw a map for the provider, for the nurse practitioner, so if you already know that it's non-tender or tender, write that down so the nurse practitioner doesn't have to fish for that information later. So whatever the patient happens to tell you, now you don't have to go through everything about that mass. The NP will figure that out. We'll go further with it, but you want to give her the most amount of information that she can, or he can, so he or she can do their job. I didn't want to leave anybody out. Okay. Another thing that our patients, oops, I went too fast, is vaginal discharge, okay, with odor. It's been there for 3 days. You want to say, have you had any itching, or is there any other problem associated with that? And that's all I'm going to say about that, because we don't know who's watching this. So, okay, for Pap smear history, we want to note, if it's available, the last 3 Pap smears. So obviously, if it's a patient that's been there for the first time, we're not going to have that, but you can say what it was by history. We want to ask if they've ever had an abnormal Pap. And this is something just to keep in mind to make it easier for the provider to figure out what the patient's Pap smear status is to put the Pap and the Culpo reports, if we have them, in order behind that Pap tab, put that all together and put it in chronological order with the last, okay, how do I want to say this, with the most recent on top, okay? So you're going from the furthest to the most recent. Okay, so we want to know, okay, we've got that. We want to know if there are abnormal results and if a Culpo is done. Many of our patients, and we know this, we refer them for a Culpo, but they don't go because they don't have the money to go. We want to know if an abnormal Pap was followed up on, and if possible, obtain the Culpo results. And we were talking earlier when we were kind of getting ready for this talk that some nurses go ahead and sign that release right then and there, fax it to the agency so that by the time they're through with the history, the Culpo results can be back. Okay, and that's just, I mean, if they don't know the physician's name, and that happens too, they don't, you know, it was 5 years ago, they don't remember where they went, then obviously we can't get them. Okay, and I just wanted to say too, let's see if, okay, here we go. If they've had any type of procedure or any type of surgery, ask them if they've had any treatment or surgical procedure done. We do really want to try to get those results. And just I tried to clear up my confusion about these terms, but a LEEP, a loop, and an LLETZ is a large loop excision of the transformation zone. All those things can kind of be used interchangeably. So a LEEP and a loop are basically the same. Okay, and cryosurgery, or in some providers use laser ablation, that's not going to give you any tissue. So there's no tissue involved with cryo or an ablation because the tissue is obliterated. And then another thing we talked about just in getting ready is if you, when you're reading your reports, if you see CKC on a report, that stands for cold knife cone, and that's done in the OR under anesthesia, and it's to obtain a large sample of the cervix to rule out cancer. Okay, so, and this is something that, you know, if you don't do the Pap follow-up, or it was confusing to me, okay, and to counsel our patients too, to say, when we do a Pap smear, it's a screening test, it's not diagnostic, it's just something that sends up red flags, and we're getting cells. A lot of times patients will say, well, they clipped something from my cervix. Well, no, they didn't. They used a brush and they used a spatula. With the cervical biopsy, they clipped something from the cervix, and that's tissue, and tissue and histology are kind of interchangeable, and that's considered a diagnostic test. And we're looking for a pathology report, and I'm going to buzz through these because we've already had this because Lori and Dr. Thomas talked about what makes you high risk. This is a change in our protocol now, and I'm just going to go over this. So if we don't know or don't have results of a patient that's had either a SIN2 or a SIN3 per biopsy or pathology, or they have a history of an ablative treatment or a LEEP and we don't have the records, we want to do the co-testing, which means do a Pap and an HPV at 12 and 24 months, and then go to every 3-year screening based on their age. Okay, and if in doubt, I've called Lori a lot this week. You can call Lori Stout, Dr. Thomas, if you, or confer with the NPs in your area, with each other, and as a last resort, call them, because it's sometimes we can't figure it out. We need to know what to do. Okay, and okay, so moving on through the our history form. Was the Pap deferred today? Yes or no? If yes, why? And there's lots of reasons we can defer. It's not time. They're on their cycle. They've douched. They're not 21 yet. And we want to put within reason our best estimate of when the next Pap smear is due. And again, if you don't know, if you're trying to figure out, okay, where in this scheme, does she fall, go ahead and get the Pap smear. You can always discard it if you figure out you don't need it. But then you can kind of sit down and go, okay, what do I need to do? Do I need it or don't I need it? So you just, if they're there, go ahead and get it. And then throw it away if you don't need it. Okay, we want to ask them about menarche. That's how old they were when they had their period, when they first started their periods. When was your last menstrual period, starting with the first day, and that's a lot of times not clear to patients, so you have to, just step it out sometimes. And if they've been on depot, or we talked about this, if they've been on depot, you want to kind of tease out when that last period was. If it was in 2005, put that down because that's our best estimate. Okay, we want to ask how many times they've been pregnant, including miscarriages and or abortions. And this is a little interactive I want to try. Okay, we discussed gravida and para, and the way we use it, or the way I was taught, okay, which was back many years ago, was that para referred to the number of pregnancies that made it past 20 weeks gestation regardless of outcome. And I think the more current definitions to say the number of pregnancies that delivered, so that 20 weeks doesn't enter in so much. But let's see if this works. Okay, nope, not ready yet. Okay, the gravida para examples are, okay, I'm sorry. The term deliveries, this is just definitions. Term deliveries is a delivery greater or equal to 37 weeks. Preterm deliveries are defined as 20 to 37 weeks as estimated gestational age. The A stands for deliveries or abortions under 20 weeks, and the L stands for total living children. And you've got it in our history form, it spells it out. But you may see this kind of denotation, okay? So if you're looking at a report from an OBGYN, you may see gravida 6, P4024. So what does that mean? Okay, so this means that, okay, so you got to remember TPAL, which stands for term, premature, abortion, living. Okay, so this patient's had 4 term deliveries, no premature, there's a 0 there, 2 abortions, and 4 living children. Okay, so we'll do the next one and see. Okay, she's a gravida 3. She's had 1 term delivery, 1 preterm delivery, 1 abortion, and she has 2 living children. Okay, so it adds up to 3, the gravida 3, if you exclude the living children. Okay, next one. So there it is. Okay, so what would this be? She's been pregnant 4 times. She's had no term delivery, no preterm delivery. She's had 3 ABs and no living children. Okay. Okay, and gravida 1, she's had, and this is where it gets tricky, and this is what goofs a lot of people up. Okay, no term babies, 1 preterm baby, and then why does she have 2 living children? Okay, if she's only had 1 delivery. Well, she's got twins. She had a preterm delivery of twins. So when you're talking about your delivery, it's talking about the pregnancy. Okay, so it doesn't matter how many babies are in that pregnancy, in that uterus, it's 1 delivery. Okay, and we want to kind of clarify too as far as what an abortion is. Okay, a spontaneous abortion is a miscarriage, and it can be denoted as SAB. An elective abortion is denoted as EAB. A therapeutic abortion is something that was done for a medical reason, where the fetus had a condition incompatible with life, or the pregnancy puts the mom's life at risk. Okay. We want to ask, when did your last baby deliver? And did you have any complications with your pregnancies? And we're going to talk a little bit more about that, because it's really important to know, get a good OB history, and one of the things to ask is the complications. So one way to ask would be, how long did you stay in the hospital after delivery? If the patient had a C-section, ask why, because that sometimes indicates a problem. Was there fetal distress? Placenta previa? Was the patient's blood pressure elevated? Did she have gestational diabetes? Okay, if a patient's had a C-section, ask her, oops, sorry about that. Okay, early miscarriages or spontaneous ABs may be indicative of a congenital anomaly. Second trimester losses may indicate an incompetent cervix. So there's interventions that can be done for those conditions. We've done a very, very good job in intervening with spina bifida because we've been pushing folic acid to all our patients as part of their preconceptional counseling, and that's something that we've been really successful at. So you can pat yourselves on the back for that. It really has made an impact as far as pregnancy outcomes, right? We want to get a good contraceptive history, what they've previously used, did pregnancy occur while they were using a method, and if yes, which method was it and why did it fail? We want to ask them about breastfeeding, and why do we want to know about breastfeeding?
It affects the type method they're on.
Okay, it's going to affect what you can give them, and because a progestin-only method is preferred, and they may not have a period if they're breastfeeding as well. Okay, we want to find out if they're having any problems with the method, the date it was last used, and then what method they desire. And one of the things I see a lot is like Depo to Implanon is method desired. So we're going to start with that. Okay, so sexual history, move on to that. So why are we getting a sexual history? Some of us have are a little embarrassed or a little squeamish about asking these questions. So
It's not meant to embarrass the patient. It's just that it has a purpose. And the patient needs to understand that it has a purpose.
So what we're really trying to do is determine their risk for sexually transmitted infections. And again, this is just going through your form. Do they have STD symptoms? And one of the big ones is any discharge. Have they ever been treated for an STD? Again, I'll kind of zip through that because that's just part of what you're asking. And you can ask it in a real, just like in the past 3 months, have you had more than one partner? Have you had a new partner? And you can do it in a matter of fact way, and I know that most of you do that.
And once they understand the reason that you're asking them the questions, then usually they give you open permission to ask those questions because they understand why.
And one thing you can say too is, before you even start getting into it, is I have several personal things I need to ask you. Do I have your permission to ask you these? I want to get a sexual history so I can better take care of you. Okay, so exposure sites. So how do we ask about that? Okay, do you engage? One way is, do you engage in genital, anal, or oral sex, or all of the above? And just say it in a very matter-of-fact way. Because one thing you can do, it's a teaching point too, is that some people don't realize that you can get an STD from having oral sex, and that oral pharyngeal cancer is related to HPV, and that anal sex predisposes a person to HIV because the rectal mucosa is thin and tears easily. We ask about condom use and encourage that. And just staying on that point a little bit, in your handouts we have a sexual exposure chart that you can use to show your patient, if they've had sex with more than one person, that their risk it's like it more than quadruples. It's exponential, that's the word. So that's something, it's a good teaching point for your patients. Okay, so moving on to the general medical history. And we've asked these questions many times, but one way to say it too is to ask it in an open-ended way, is to say, what health problems do you have? Or tell me about any hospitalizations or ER visits. If it's available, look back at the previous year's history. If they've been there before, just see what, you know, you don't want to do it at the beginning. You kind of want to see what they tell you, but then look back and see if they didn't tell you something that they disclosed last year. Something happened in one of our clinics where a patient had, 5 years ago, had a DVT, and it got left off the subsequent histories, and it's because the patient didn't say anything about it. And so then the nurse practitioner that saw her happened to flip through the chart and find it buried in the back there, and it was like, oh my gosh, we've been giving you estrogen-containing pills all these years, and we didn't know you had a history of DVTs. So just be aware of that. Okay, you want to ask about any change in medications. Has there been a change in your medical history since last year? And then, like I said, be sure to bring forward any history from years past. And this is something we're going to talk about. Beth Allen's going to be talking about this later, is the use of the problem list, because we just wanted to make sure nothing got left off, that we're aware of everything that was going on with the patient. Okay, and again, in the general medical history, we want to ask the questions in a way that the patients can understand. And you really have to adapt it to your patient. Some people may not know what anemia is, but if they've had it, they probably know. But you might want to say, that, have you had low iron or low blood? I've heard that expression. In talking about the autoimmune diseases, you know, somebody may not know what an autoimmune disease is, but if you ask them, do you have problems with rheumatoid arthritis or lupus, then that's going to key in. And then what are we looking for? Okay, so something I'd be thinking about is, okay, so if they have lupus or rheumatoid arthritis, are they on steroids? Are they one of those people that's immunosuppressed that are considered high risk? Okay. In talking about blood disorders, we want to ask them if they've had any problems with bleeding disorder, any clotting disorder, have they had a blood transfusion, and why did it happen? And sometimes things will come out there that, well, I had one when I had the premature delivery of my baby, and they didn't give you any complications in the OB history. So it's like, sometimes it's just like trying to put a puzzle together. You want to ask about cancer, diabetes, domestic violence, and that safety screen that we have in our assessment on the CHR 12B is a good thing to refer to. That's a good opening just to say, okay, what are you safe in your home? Okay, we want to ask about drug use of alcohol. Some people say, how many cigarettes do you smoke? Instead of saying, do you smoke? And if they say, well, I don't smoke any cigarettes, then you know they're a non-smoker. Do you use any other tobacco products? Because our patients use e-cigarettes and snuff and chewing tobacco at times. Okay, and we want to ask about fibroid tumors, GI disorders, do you have any digestive problems, and headaches. This is a big, Deborah talked about PCOS being a big bugaboo, big bear. Headaches is something that we want to discern what's going on with our patient. And a way to start would be, tell me about your headaches. We don't want to call something a migraine if we're not sure, because it limits our birth control options. Okay, and there's a, just for sake of time, there's a great section about how to tell if something's a migraine in your family planning protocol starting on page 51, and there's also a great section on aura, like determining what is or isn't an aura. And we're going to flip through these because I know I'm getting short on time. Mental health disorder. If somebody asked me if I had a mental health disorder, I would say no. But if somebody asked me if I have anxiety, I would say yes, today, for example. So And then just seizure disorders, just go on through. And a way to ask about family history, a good way to start this is, are your parents alive and well? Because if they're dead, you want to find out what they died of. Okay, what health problems do or did they have? Same thing with brothers and sisters. And you want to really key in on the first degree relatives, and Beth is going to talk about that a little bit more later. So your first degree relatives are the ones closest to you. Your mom, dad, brother, sister, child is a first degree relative. So those are the ones we really want to key in on. Okay, so let's go on. Okay, so this is important. We want to ask the age that a first degree relative was diagnosed with breast, ovarian, uterine, or colon cancer, because those issues have a close family, well, they're related. How do I want to say this? Help me here. They have a good, have a,
Genetically predisposed?
yes,
That's a good way to say
inherited genetic predisposal. Thank you. Okay, we don't need the history of cousins or distant relatives. And it's surprising, you want to ask them about your blood relatives, because they'll say my sister-in-law had cancer, and we don't, not that we don't care about her, but we don't need to know about her to take care of this patient. Okay, so then, and we don't want to document everything word for word, because sometimes we need to redirect our patients. And for space, if we need more space, we go to the comments of applicable section on the CHR 12A, or turn to the CHRB. You can always use the progress notes. Okay, and this is real quick on this. The CHRB, and we'll go show that. You want to give yourself credit for doing all those teaching things. So give yourself credit for talking to the patient about all these things. And there you'll see the safety screening. Like I said, you feel safe in your home. There's that. The PT +3, so 3 take-home points. Okay. And just for what we found on QA audits, just wanted to tell you that back, and we've preached this over and over again, and it's really hard on this, we'll go back to this one, not to write in the margins of this, because then it looks like something's been added, and you don't want to cross out another provider's notes. And so this was an example. Sometimes there'll be like the date the Pap smear is due, it'll be 2015. Well, it's really due in 2016. We'll just put a little asterisk there and then go to the applicable comments section and just make your note there. But because, and then this is another thing, if you're following up on a deferred physical, okay, this is what we've seen some people do, is that they rewrite the whole deferred physical, or the whole history rather, and the physical, or okay, help me here. The history lasts for
a year.
Yeah, it's good for a year. We want to do the exam sometime within 6 months. So if there's an update, just update the last menstrual period, you know, number of sex partners, or when they last had intercourse. So you don't have to redo the whole thing, because that's going to save you a lot of time. And I know you know, some people just want to start with a clean slate, but, you know, just add it to the additional comments section. And if needed, go to the B or use the progress notes. Okay. Okay, and we've talked about this before, but let me just say it again. If you're doing a deferred physical, put the label of the exam date, or print a new exam form and use that, so that the dates match, so that the date that you're doing the physical matches the date that the NP is signing off on this physical. Okay, and then another suggestion, and this is just something that we found in doing chart audits, is if somebody reviews the chart after the clinic is done, either that day or the next morning, and it can be the clinic supervisor or designated RN, you'll find things that have been left off, and you'll do yourself and your NPs a favor by having that for her or him to sign the next day or whatever, instead of having it go in the chart and get filed. And, you know, if it's just a matter of, well, you forgot to sign this off, and that happens to all of us. So I love it when somebody goes behind me and says, okay, follows up on me, because it's everybody, all of us can make a mistake. So that's basically all I have to say. Oops. And we'll pass it on to Beth Allen, and she's going to talk about soap notes and a few other things.
Okay, hello to all, and hope y'all are doing well out in the Alabama Department of Public Health world. So we're going to segue right from the mountains and the bears into the ocean. So we're jumping in the water with soap notes, and if it ain't written down, it didn't happen. And that's the way the old saying goes, and we've heard it for years. We just want to tweak our process. We want to fine-tune things. We really do a good job with this, but there's just some particular areas we want to touch on today as far as improvements go, especially with the efficiency piece that's coming our way, and we want to be best prepared so that we work like a fine-tuned oil machine. All right, in 2011 we implemented the soap formatted charting, and Gabi and Ramona rolled that out then. And so now, why? Why are we up to this again after we've already talked about this? Well, effective January 1st, 2014, that's an important date, under the Affordable Care Act, well known now as ACA, women's preventive and wellness services are one of the essential benefits. So we know that we're here to stay. How we do business will change, but we know that it's an essential part of the ACA. Efficiency of our medical legal document has never been more important. Notes are legal documents, and of course, I have a lawyer sitting here on the panel with me, so I want to be careful how I say these things, but lawyers and insurance companies don't believe that additional things happen after the visit. It is very suspicious of fraud to go back and make any changes to your note. All right, so I'm not saying all lawyers are sharks, but you know what I mean. We do have a big legal risk category here, and we just really want to emphasize that we need to do this very well. Notes do improve if we work at this, so we are a work in progress. I'm a work in progress every day, and that's what this is about. Statistically, we leave off information that we gather from the patient. I know I'm guilty of that as well, and it's not entered into the written note. So it is our now and it is our future, and what I mean by that is we will emerge from our written notes into the electronic medical record, and that is right around the corner. I know y'all have heard that before, but we are going that direction, and with that, the SOAP format will go directly into the EMR. Most all EMRs use a SOAP formatted charting, so we just want to really tailor our process at this time. I think what I want to do now, if we can, is go to our 12A, page 2, which is our physical assessment. And rather than go slide by slide here, I'm just going to walk us through this. I think we mostly all know the essentials of SOAP. Before I start into this, I'll just brief on it for those of us who are new. The S in SOAP stands for the subjective data, and that's entered at the top of our assessment form there. So those are things like the patient's chief complaint, you know, what brings them in today, what are their pains, problems, concerns. Those are the patient's words, and that's what we write there. Moving into the objective data, that's the physical assessment. That's our exam. That's our complete page there. From general appearance all the way down to the very end, that is your objective data. Just to touch on that a minute, as far as general appearance goes, back at the top of that form, often we'll put things like well-developed, well-nourished patient in no apparent distress, or 30-year-old gravida 1, para 1, in no apparent distress. But what we want to tweak here, what we want to fine-tune, is the things that make our patients unique in that, so that if it is a patient who has a flat effect, you can actually write that there. If it is a patient who is very friendly and talkative, you can actually write that there. You know, whatever's going on with that patient that will trigger you about that patient if need be, and also make that documentation unique to that patient and their identifiers. Things like multiple tattoos, truncal obesity, we've talked about PCOS. Those are very pertinent things that we do need to include in our documentation, and they can be written right alongside of our checkoff boxes in those appropriate sections. One particular, of course, we're women's health oriented, and one particular area we wanted to talk about is the breast documentation. So with the breast documentation, if a patient presents with a palpable clinical breast mass, then we should at that time, in that documentation, at the very time that that's going on, make this note. So it shouldn't be something that's put off. We should write, you know, which breast is affected, right or left, start it that way. So right breast mass. We actually document that by the location on the clock. So 12 o'clock, border of the areola. That's a very good way to define exactly where that breast mass is. You want to note the size after that in centimeters, approximately 1 centimeter. You want to be sure that you denote the shape. Is it round or irregular? Is it firm or soft? Is it mobile? Is there any associated symptoms with that? Is there dimpling at the nipple? Is there retraction of the nipple? Is there any kind of dimpling over the mass? And of course, as far as documentation goes, including if there's any involvement of axillary lymphadenopathy. Those are very important markers and something that will clearly define, paint the picture, if you will, of what's going on with that patient that day. If you do find and palpate a mass in the breast, we should stay away from things that are diagnostic in our description. So we shouldn't say cystic in our description. We shouldn't even say solid, because those are markers, if you will, are really diagnoses that come from ultrasound mostly. And those are not the types of ways we should describe. We want that breast mass not to be malignant, and so a lot of times we lean our documentation towards cystic or something along those lines, but we really shouldn't say that at that time, because we can't diagnose with our fingertips basically what's going on with that breast mass. And another piece that sometimes gets left off in this is what's going on with the other breast. So is that breast normal? If so, then you need to put left breast normal. You know, you need to make a notation so that that's not left off in your documentation. Often with our patients, we have a lot of lumpy, bumpy tissue, as you often hear us describe, and in that tissue, you don't feel a palpable mass. It's consistent throughout both breasts, and the way that is best written so that it clarifies what you have palpated in that breast tissue is bilateral nodularity that is consistent with the normal breast exam without any discrete palpable mass. That's a really concise way to say that that patient has lumpy, bumpy breast tissue, and if you looked back at that note, or if anybody else looked at that note, they would know what we were saying in that. Okay. As well in, you know, the cervical component, when we're actually documenting what goes, if you'll just move on to the cervix, when we actually document what goes there, of course you can put nulliparous or paris, but you know, if you've got ectopy, or if you've got a cervix that's friable with the brushing, if you know the Pap Smear caused excessive bleeding. Those are types of things that we want to make note of as well. It could mean infection. It certainly could mean an abnormal process is going on. So just be sure that you do explain any abnormals that identifies what's going on with that patient in that section as well. We'll move on down to the A and P. Okay, so A is assessment, which includes our diagnosis. Okay, it also includes our risk factors, and we want to clearly define these. This typically throughout, since 2011, has been done as many different ways as there are people out there writing it down. So, and, you know, I do it different, and Gabi does it different, and we all do this differently, and that's okay, but there should be some standardization there, so you can hear our theme is all around standardizing our process. And the standardization should either be numbered or listed, but you start with A and you clearly define what diagnosis that you're making on that patient. So, for example, you can say normal female exam there. So that's a definition or a diagnosis of what's going on with that visit. You can also list obesity, BMI of 35, however you want to list that, risk factor. You can also list hypertension, controlled or stable or unstable, however you want to list that. But it should be a defined listing after A so that you know that. And then clarify what your plan of care is, what you've done that day. That includes your orders, your contraceptive method, any test that was done, your counseling, your teaching, anything that's pertinent to the plan of care that will proceed from that point on. What happened today and what will proceed from that point on is what should be written. So you can number them, or you know, you can put the letter A and then have a listing that goes across the line. You can have a listing that goes down. Just make it definitive so that it is separated and we know that what is your assessment and what is your plan. That's really what we wanted to sort of take home there. A lot of us are already doing that, but we just want to fine-tune that process in our documentation. All right, and as we talk about documentation and we segue on into ways to help us with documentation, we are now going to unfold and roll out something that's been in the making for a very long time. Let me just flip through these. All right, so here we are. We're the sharks now, and we're going to attack the problem list. So the problem list is something that many of you know has been on the back burner, and we want to roll it out today and let you know how this is going to work in our chart system. It is the direct, so why? It is the direct recommendation by ACOG that we include problem list. It's a part of modern practice. It's a part, again, of the EMR presentation. We want to make sure that everybody understands that the problem list enables us to have a centralized location for a quick look at what the overall problems and conditions for that patient is. It will improve our communication with each other, and it will help our clinical decision making so that we can see that as a quick glance, and we won't miss the DVT that happened 5 years ago because it'll be on that page. It'll improve the management of chronic conditions by having this. And just to move forward, this is an example, and I want you to refer to your handout. My slide is a little bit different than your handout. We have asked, and we appreciate everybody's input on recommendations for the problem list. And what we're rolling out today in your handout is what we're working on. This is currently being reviewed by the CHR committee, and we hope to have this implemented very soon. Just to explain the way we want this to go, the problem list will be the top page on the right-hand side of your chart. When you open the chart, on the right-hand side will be the problem list. On the left-hand side will be your CHR1. So that that will be an automatic red flag system to pull your eye to the conditions and problems that's going on with the patient. The date is not necessarily the date of the diagnosed problem or the date of diagnosis. It's just the date that we identified the problem. And then the listing of the problem, as you can see, is just a varied list of what's going on that's pertinent to that patient's care. It can be breast mass, it can be consult, it can be abnormal mammogram. One thing of big importance here is we still want everybody to do their follow-up piece, not use this as a follow-up system of any kind. Remember, this is a quick glance of problems. We want everybody to still use their breast tabs and their Pap and pelvic tabs to do the mammogram and the Pap smear follow-up as far as that goes. But you can list the abnormal mammogram or the abnormal Pap smear there so that you get a quick glimpse of what's going on. We do want to have a third column there where you can denote if that problem has been resolved or if it's still ongoing, so that it keeps you abreast of what's going on with that. All right. So let's segue from that problem list, which you'll see more of that coming, so we just wanted to unfold that. We all realize that most days we feel like a very small fish in a very big ocean of the task that we have ahead. And as far as our legal aspects into our medical management and as our history taken and our SOAP notes, that this is all a process that can be very frustrating. This process can be better organized through something that's called Well Women's Care. I want to just refer you to our January 2013 Nurse Practitioner article for reference on this, and I'm just going to go through these slides briefly so that you know what this is about. This actually recommends that we think about our care in 4 age groups: the adolescent, 13 to 18, the young woman, 19 to 39, the mature woman, 40 to 64, and the older woman, 65 and older. As we look at the adolescent, what we really need to take home here is this is our prime time to establish care with a young teenager who's scared to death about coming into the health department for her care. And it's either going to be a time where we lay a good foundation and make it easy for that patient to come in and see us for many years for their care needs, or it's going to be a time when we completely drive them away. It's our choice, and it's a good time to do a lot of teaching and get a lot of groundwork done. Think some key terms here: screen, guide, and immunize. Okay, so in those age groups, we have a lot of possibilities of developing problems that relate to PCOS. You want to guide these patients, teach them what's important. Immunization, we should automatically be thinking about the HPV. In the young woman, 19 to 39, effective contraception ought to be the first thing that comes to your mind. And of course, we begin our cervical cytology at 21. We have a lot of STD awareness in both the adolescent and the young woman. With effective contraception, you want to go and really think about long-term contraceptions. Our LARCs that we have available are the implant, and then of course referring them for the IUD. To move on into the mature woman, remember this is a big transition into menopause. This is the time when cervical cytology becomes more important and you want to initiate your mammograms. The older woman, 65 and older, the number one death risk from 40 through 65 and older is still cardiovascular disease, as we've touched on before. Respiratory illness is coming in as a high risk for secondary to increased smoking. You still want to do your annual mammography. Remember, in the well woman exam with our patients, the osteoporosis importance. With Depo, it doesn't matter if they've been on Depo 2, 5, or 10 years. They don't have to stop Depo because of that, but we do want to teach them and screen them appropriately. With colorectal cancer, our screening for that starts with the FIT test that we have at 50, but at 45 in the African American woman, and any family risk. Concerns at any age include mental health, sexual dysfunction, domestic violence. Remember to ask the right questions. With someone that is in a domestic violence situation, you want to be sure that you directly are asking, is someone hitting you, pushing you, slapping you, and that way you will hopefully elicit a response from them. In conclusion, as far as the process goes, legal all the way to medical into the way we document, is imperative that we focus on our quality as we move into more quantity with our visits. We can do this. We have to support each other in this. And we always have to understand that our patients are our mission here. We can share ideas, grow together, and commit to excellence. Most of our days do have this vast ocean of tasks, but hopefully at the end of our day, we have helped someone. And when we have helped someone, we can go home knowing that we've done the very best for that patient that we can do. We thank you all, each and every one, who give care to our patients, and we just look forward to our time to grow together. Thank you again.
Okay, thank you. Well done, ladies. Now is your opportunity to email your questions in or to call. We want to encourage you to do that. I think it's the relevance of what they've shared. Standardization is not only important for efficiency, but it's making sure that we meet the regulations that Title X sets forth for us in order to receive our federal funding, and they've got to be documented. And also, it helps you to say to the patient, I ask these questions of everybody that comes in. So it automatically puts them at ease to know that when you're asking sensitive questions, it's not because I particularly think that you look like somebody who may get a sexually transmitted disease or that you're being abused, but it's just a standard set of questions we ask all our patients. So I think when you start off with that, that really helps them. But as we're waiting on questions they're throwing things here in the studio. As we're waiting for your questions to come in, we did during the break ask Samaria to comment on a couple of things about the ARIA report. We're going to give you that opportunity to do that now.
Okay. One of the things that we've noticed is that when doing the ARIA reports, for each type of report that you all provide to us, there's a place for a brief description. I guess I should go and remove the term brief because we really need to know what's going on, what's happening. And too often we're not getting enough information. So we end up having to send follow-up emails and that type of thing. I think it's very important to know that I'm not the last stop with a lot of these ARIA reports. So with the terminology in those, people can get over my head in terms of me not understanding exactly, whether or not this was a professional practice issue or not. But you need to understand this is going to Valerie Cochran. This is going to our physicians and our doctors. And I don't know about you all, but whenever I'm presenting something to Dr. Thomas or Dr. Miller or any physician in our office, I want to put my best foot forward. So we would ask that you all make sure that you complete that and provide as much information as you possibly can, and that would prevent follow-up emails to ask you those questions. Another thing that I wanted to touch on has to do with minors and STDs when they come in for a visit. Let's say that we know what happens when you're 12 years old and the person comes in by themselves and they sign for their own services. But let's say that a 12-year-old comes in and they're brought by their mother for family planning. So the mother is actually signing for the record, signing for those services. And it just happens to be that you find out during that family planning visit that the person is positive for some type of STD. Well, in those situations, what we generally say is the person that signs for the record is the person who owns that information. And since the mother was actually bringing them in for a family planning visit, that would be part of that visit. So the parent would have access to that information. That would be very different than the 12-year-old coming and presenting themselves themselves at the health department. So I did want to clarify that. Because I think that that's very important. I'm actually the attorney who goes around the state defending, providing people's STD information. But I think this is a really important clarification that we want to provide the parents access to that when they sign for the record. And one other thing that I wanted to touch on when it came to communicating between county health departments, I know one of the things that I said is that going into the future, we won't be faxing STD information back and forth. But as it relates to county health department to county health department, there are ways that you can still communicate that information to one another. I know in a number of places we do have scanners where we scan information in and email it in Lotus Notes. Lotus Notes is a very safe and secure, I don't know that much about technology, but I'm told that it's a very safe and secure way for us to communicate. But if you don't have a scanner that you can email that information to one another, use hand mail, use regular mail to send that information at the time that you're not able to communicate STD information by faxing.
Thank you, Samaria. I'm told that we have no phone calls and we're actually out of time. So please, if you do have questions later on, you know how to get in touch with these ladies through the email, or you can make phone calls. We're here to help you do your job better. So with that in mind, I'm going to let you go so you can get back to it. And thank you so much for joining us today. Thank you for all you do, and you have a good weekend.